So, I welcome you all to yet another session of the Residence Corner module. These sessions are arranged by the Department of Neurosurgery at Liaquat National Hospital. Today, we will be discussing the anatomy of middle cranial base. Dr. Alisha is A1 resident at Liaquat National Hospital. We do not have an expert panelist today, but because our expert panelist had an emergency case. But we do have Dr. Salman Sharif. So Professor Salman Sharif will give his expert opinions at the end. I urge you all to ask questions because this session is for the residents and arranged for the residents. Dr. Alisha, can you please start your presentation?
Yes, sir. So we'll be discussing today about the middle cranial base. I have divided the presentation into the four parts, the endocrine, basically two parts, the endocrine surface and with its contents, and the endocrinial and the exocranial surface with its contents. So coming to the endocranial surface of the middle cranial base. So we have basically this central region with basically the middle cranial base is formed by the sphenoid and the temporal, largely by the sphenoid and the temporal bones. So the middle portion is formed by the sphenoid bone and the body of sphenoid, and the lateral part is formed by the greater wing of sphenoid and the temporal bone. So the medial portion contains this region is the planum. This region is the planum sphenoidale, followed by the chiasmatic sulcus. This region, basically, which is anterior to the sella turcica, is the tuberculum sellae, and these processes are the medial clinoid processes. The dorsum, the sella turcica or the hypophyseal fossa houses the pituitary gland, posterior to which is the dorsum sellae. These anterolateral segments of the dorsum sellae are the posterior clinoid segments. This region represents the clival region. So coming to the lateral edge, we have the greater wing of the sphenoid on the lateral side of at the lateral border of the middle cranial base. This wing connects to the body of sphenoid via the anterior and posterior root. The anterior root also forms the roof of the optic canal, and the posterior root here, it forms the floor of the optic canal, which is also known as optic strut, and it basically separates the superior orbital fissure from the optic canal. In between these two roots, obviously we have our optic canal. So coming to the foramen of the middle cranial base, here we can appreciate at the junction of the lesser and the greater wing of the sphenoid, the superior orbital fissure, which basically contains the ophthalmic, the trochlear, the oculomotor, the trochlear, the ophthalmic division of the trigeminal, the abducens nerve, along with the recurrent meningeal artery and superior and inferior ophthalmic vein. Here we have the foramen ovale, which connects the middle cranial base to the infratemporal fossa. This foramen contains the mandibular division of the trigeminal nerve and the lesser petrosal nerve, which enters to the infratemporal fossa to join the otic ganglion, which will eventually supply the parotid gland. Here we would have the foramen rotundum, which is again separated by the superior orbital fissure via the maxillary strut. We have the foramen lacerum here, and this region of the petrous part of the temporal bone will be containing the internal carotid artery or the carotid canal, which contains the internal carotid artery along with its sympathetic nervous plexus. So again, another magnified view or a more clear view for better visualization. We have this region, which is the planum, followed by the chiasmatic sulcus. At the tuberculum cilia, we have the medial clinoid processes, the anterior clinoid processes, the optic canal, the optic strut, the foramen rotundum, the maxillary strut. Here, bilaterally, we have the depression, which is for the internal carotid artery, the cavernous part of the internal carotid artery. Here we have the foramen lestrum, from at the lateral border of which emerges the internal carotid artery, the cavernous part. Basically, this is the foramen ovale. Here would be the foramen spinosum. The foramen spinosum basically contains the middle meningeal artery and middle meningeal vessels, which connect the infratemporal fossa to the middle cranial base. These arteries are the branches of the maxillary artery, which basically house in the intratemporal fossa, which we will discuss later. This region is again the clivus. Okay, this is the petrous part of the temporal bone, which I have shown in a separate part. So this is basically the temporal bone, basically the right temporal bone. This is the squamous part. This is its mastoid and osteoid part. This region is the petrous part. Here we have the trigeminal depression followed by the trigeminal prominence. This region is the meatal depression, which overlies the auditory canal. Here we have the arcuate eminence, which basically corresponds with the superior semicircular canal. Here is the tegmen tympani, which is basically a paper thin bone which forms the roof of the middle ear cavity and contains the ossicle, auditory ossicles. So moving forward to the contents of the endocranial surface So again, laterally it contains the temporal lobe, basically the inferior surface, which has a parahippocampal occipitotemporal and the inferior temporal gyrus. Here we also can appreciate the semicircular canals. This is the superior semicircular canal, which corresponds to the arcuate eminence. Here would be the tegmen tympani. So again, for the orientation, this is the anterior part, this is the posterior, and we are looking at the left temporal lobe. Here we have the trigeminal nerves at the Mickle cave, its motor and the sensory roots. Here is the semilunar ganglion of the trigeminal nerve. These are the divisions, V1 passing via the cavernous sinus into the superior orbital fissure, maxillary division entering into via the foramen rotundum into the pterygopalatine fossa, and the mandibular division entering via the foramen ovale into the intratemporal fossa. Here we have the geniculate ganglion, from which arises, and this would be the facial nerve, from which arises the greater petrosal nerve, which will eventually join at the foramen lestrum with the deep petrosal nerve to form the Vidian nerve, which we will see later. So these are the components of the medial basically surface. Here is the region of the sella, which will contain the pituitary gland or the hypophysis cerebri. This is the interconnecting sinus, intercavernous sinus, which connects the two cavernous sinuses. Laterally, we will have the cavernous sinus. So for the better orientation of the cavernous sinus, I have taken this picture just for the orientation and how the cavernous sinus is formed. It is basically formed by the two layers of the dura, one facing the brain and the other facing the body of the sphenoid. The inner layer, which faces the bone, splits at the lateral edge to enclose the oculomotor, trochlear, ophthalmic and the abducens nerve, and also the internal carotid artery resides within the cavernous sinus. So again, coming to the contents, we have this abducent nerve, which which is coming from the pontomesencephalic junction and entering the. This is the Gruber's or the petrosphenoidal ligament, which forms the Dorlos canal, which contains the abducent nerves along with the inferior petrosal sinus, which eventually will enter the cavernous sinus. So again, we have the greater petrosal sinus, which drains the cavernous sinus into the transverse sinus, petrosal sinus. This is the portion of the internal carotid artery, basically the cavernous portion followed by the clinoid portion. This is the ophthalmic branch entering the optic canal with the optic nerve. This region is again the chiasmatic sulcus. Here is the posterior cerebral artery, and this is the superior cerebellar artery, between which the ophthalmic nerves passes to enter the lateral wall of the cavernous sinus. So here would be the trochlear nerve, which would come around the midbrain and eventually enter the lateral wall of the cavernous sinus. Here is the trigeminal nerve, the motor and the sensory roots forming the dilation here, which is the semilunar canal at the Michel's cave. These are the ophthalmic, mandibular, maxillary, and ophthalmic divisions. Here is the middle meningeal vessels coming from the foramen spinosum. Okay, so moving forward, this is another view at the base of the middle cranial fossa. This is the central part, this is the peripheral part. This is the greater wing of sphenoid. Here, the petrous part of the temporal bone or the carotid canal has been de-roofed to show the petrous segment of the internal carotid artery, which is moving forward. This region, the cochlear apparatus or the semicircular canal have been exposed, which will the superior semicircular canal, which will eventually be lying over the arcuate eminence. Here is the tegment tympani. Here would be the mastoid antrum. So this is the Michel's cave containing the trigeminal ganglion. It's V1, 2, and 3 divisions, which are lying laterally to the cavernous sinus. Here is the cavernous and the clinoid portions of the internal carotid artery. This is again same picture, magnified view, just a deeper section where the greater wing of the sphenoid has also been removed. And this region is showing the infratemporal fossa containing the pterygoid venous plexus, which connects to the cavernous sinus via a vein into the foramen, into the emissary foramen of sphenoid bone. So these pictures again are showing the magnified view. Here is the trigeminal nerve, its branches, internal carotid artery, the vestibulocochlear apparatus, again the petrous segment of the internal carotid artery, which passes under this petrolingual ligament and then enter the and at the level of the lustrum, it becomes the foramen lustrum. It becomes the cavernous sinus, cavernous segment, followed by the clinoidal segment and so on. Here would be the geniculate ganglion, from which the greater petrosal nerve is arising, and at this region of the foramen lustrum, it is joined by the deep petrosal nerve to form the Vidian nerve, which will eventually be opening via the Vidial canal into the pterygopalatine fossa. So we have discussed these figures. So coming to the exocranial surface of the middle cranial base. So it is largely formed by, again, the central and the lateral portion. Central portion encompasses the sphenoid body and the upper and the clavicle part of the occipital bone. which basically corresponds to the sphenoid sinus and the nasopharynx. Laterally, it is formed by the greater wing of sphenoid. Here would be the sphenoid bone. This is just an open mouth view basically for the orientation. This is the maxilla, this is the sphenoid bone. This is the temporal bone. Its petrous part, its styloid process, all of which, the zygoma, all of which forms the lateral parts of the exocranial surface of the middle cranial base. The middle and the lateral parts are separated basically by the medial pterygoid plates. Again, another picture, the lateral oblique or side view showing the temporal fossa, the infratemporal fossa. The infratemporal fossa, which will be connecting to the pterygopalatine fossa via this pterygomaxillary fissure. So coming to the inferior portion towards the foramen. Here is the foramen lacerum, which is basically lying at the union of the occipital and the petrous bone, and at its lower end, it has the fibrocartilaginous tissue to form the inferior wall of the carotid canal. It basically, so here we can see, here this is the carotid canal, and in this magnified view, we can see the carotid artery entering the carotid canal, and at the level of foramen lacerum, it is bending to enter the cavernous sinus. Here is the Vidian nerve, which will, at the level of foramen lacerum, which is formed by the veil lying here connecting the infratemporal fossa to the middle cranial base or the middle cranial fossa. Here would be the foramen spinosum, and again connecting the infratemporal fossa to the middle cranial fossa. Same picture, magnified view, stylomastoid foramen, carotid canal. In this figure, we will be seeing this region which encloses the infratemporal fossa, and this region which is the Rosenmüller or the pharyngeal fossa or the pharyngeal recess, also called the parapharyngeal fossa. So infratemporal fossa, coming to the boundaries, it is basically formed medially, I will see in a picture later, medially by the pterygoid process here, laterally by the mandible, which has been removed here. We can see the this cut edge of the mandible. Anteriorly, it is formed by the posterior wall of the maxillary sinus and the greater wing of the sphenoid body. The posterior medial edge, as we discussed, is formed by the Rosenmüller space. The maxillary artery, the pterygoid muscle, and the mandibular nerve, along with the pterygoid venous plexus, this is the pterygoid venous plexus, are its contents. So magnified view, in this picture we have shown the Rosenmüller fossa or the pharyngeal recess. Basically, the Rosenmüller fossa is divided into the pre and post styloid segments. Here we can see the pre-styloid segment, which is basically a fat containing space between the medial pterygoid muscle and muscles and the nasopharynx, containing the tensor villi palatini muscles and the eustachian tube. Here we have the post-styloid region, post-styloid segment, which is containing the internal carotid artery. Its anterior border is basically formed the anterior carotid sheath, and it contains the internal carotid artery, the internal jugular vein, and the cranial nerves 9 to 12. Moving forward. So we have this picture for the orientation of the infratemporal fossa. Here is the pterygomaxillary fissure, which basically joins the infratemporal fossa to the pterygopalatine fossa. We have the medial wall, which is formed by the pterygoid process, and laterally the mandibular bone has been removed. Here we can see the mandibular fossa, and anterior to it, obviously we will be having the posterior wall of the sphenoid maxillary sinus, and superiorly we have the greater wing of sphenoid. So this is coming to the pterygopalatine fossa. We have in this figure, we have removed, this is the anterior region, this is the posterior region. We are seeing the left side. We have removed the posterior wall of the maxillary sinus as shown here. So coming to the maxillary sinus, it has this posterior bone is the sphenoid bone. So basically the pterygopalatine fossa connects via different spaces. Laterally, it opens via the pterygomaxillary fissure into the infratemporal fossa, as we discussed here. Medially, it is connected to the nasal cavity via the sphenopalatine foramen, which we will see in later slides. Posteriorly, it has this foramen rotundum, which is separated by the superior orbital fissure via the maxillary strut. It will have opening into the eye via the inferior orbital fissure as well. It receives the Vidian nerve via the Vidian canal. And moving forward, this is the same picture that we discussed earlier. It is just the magnified view of the same picture showing the infratemporal fossa and the Rosenmuller or the parapharyngeal fossa. So again, the pre and post styloid segment. Pre-styloid separating the medial pterygoid or the infratemporal fossa from the nasopharynx containing the tensor villi palatini and the eustachian tube. The post-styloid segment containing the carotid artery and the internal jugular vein, also containing the cranial nerves from 9 to 12. Here is the infratemporal fossa. If we remove this lateral pterygoid muscle, we will be entering into the infratemporal fossa. So here we have removed the medial pterygoid muscle to expose the infratemporal fossa. So this is the infratemporal fossa. This is the lateral pterygoid muscle. This is the maxillary nerve mandibular nerve arising from the foramen ovale into the infratemporal fossa along with its branches. In this picture, we are looking at the pterygopalatine infratemporal fossa again at the magnified view connecting the pterygopalatine fossa, infratemporal fossa connecting to the pterygopalatine fossa via the pterygomaxillary fissure. In this figure, we have removed the pterygoid process just to have a better orientation of the pterygopalatine and the infratemporal fossa. Here is the pterygopalatine ganglion, the mandibular maxillary division of the trigeminal nerve, the Vidian nerve, joining the the pterygopalatine ganglion. Here we would be having the otic ganglion in the infratemporal fossa as well, which will provide the secretomotor, which will receive the lesser petrosal nerve, and its secretomotor fibers would be supplying the parotid gland. So this is another figure in which we have exposed the inferior surface of the carotid canal to expose the internal carotid artery. So this is the petrous segment of the carotid artery, internal carotid artery, which would be entering via the foramen lustrum into the cavernous sinus. This is the salar region. Again, this is the clivus. These are the maxillary and the mandibular divisions of the trigeminal nerve and their respective fossa. So moving forward, this is just a coronal section at the level of the ethmoid sinus, where we can appreciate the pterygopalatine fossa. Here we can see the opening via the sphenopalatine foramen into the nasal cavity medially, posteriorly. At the greater wing of sphenoid, we have this foramen rotundum, from which the maxillary division of the trigeminal nerve is arriving. Here would be the Vidian nerve. This is the magnified view. We can see the Vidian nerve coming from the Vidian canal or the pterygoid canal, joining the pterygopalatine ganglion. This another communication of the pterygopalatine fossa is the inferiorly it opens into the palato-vaginal canal, which contains the greater and greater palatine nerves and vessels. So that's all about the contents and boundaries of the middle cranial fossa.
Thank you, Dr. Alisha, for such a detailed presentation. Now I'd like to request Professor Salman Sharif for his expert opinions. I know this is the 11th hour, and so just his opinion, your expert opinion would do.
Can you hear me, Saad?
Yes, we can hear you.
Okay, I think what has happened over the time that you've been conducting all these brilliant anatomy sessions is that every session people are improving day by day, and everything is becoming easier and easier. And I can see that, with the initial talks when people were hesitant, etc., now majority of the time they know the stuff already because it's been covered in some other session. So I think the talk that Alisha gave was very good, very comprehensive, included everything. This is an important area because there are important elements in these middle fossa. And from our perspective, obviously, the cranial nerves are important, the carotids are important. And now, since we are doing bigger and bigger surgeries, infratemporal fossa and approaches in this area are important. And obviously, the medial part is our bread and butter, and we routinely go into that area. So I think anatomy of this area is pertinent to our weapons that we have when we are assessing patients in this area. With the problems that we have. And usually you get tumors, you get pain management, you get infections in this area, and all neuralgias. And that all can be, if you know the anatomy, then life can be much simpler. And I think what's happened is slowly and gradually, everybody who's been attending these meetings have learned so much that these sessions have become so easier to understand. And even if you're just listening, not even looking at the slides, it's majority of the people understand what's happening. So I'm grateful to Saad, who's done these sessions, and hopefully we'll be able to continue these, and hopefully we'll be able to share knowledge worldwide. Thank you, Saad.
Thank you, Dr. Salman, for your expert opinion and joining at the request on the 11th hour, which shows your interest towards education in neurosurgery. You can find, obviously this was a complex topic, but if you want to go back to this lecture, you can find this on the YouTube channel of the LNH YouTube channel. If there's any questions by the participants, we'll be happy to take it. If not, then we will conclude the session. If there's any question, you can use the chat box. If there's any question for Dr. Alisha. I don't think there's any questions since Dr. Alisha was so good at the lecture. Thank you again, Professor Salman, for your involvement. We'll see you all next week, where we'll be discussing another topic. Take care of yourself. Thank you, everyone. Thank you, Dr. Salman, for joining.
Thank you, sir.
Thank you.